I am Cynthia Brown. I am at Indiana University, where I am an associate professor of clinical medicine, as well as the director of the Adult Cystic Fibrosis program. In my past lives as a physician, I trained in sleep medicine and did some research in sleep disorders many years ago. So I have a good background across a variety of sleep disorders. And today I'm going to be talking about sleep health and cystic fibrosis and give you some tips on how to get a good night's sleep. With any talk, I like to do my financial disclosures, and the reality is I have none that are particularly relative to this talk. Like most CF clinicians, I perform a variety of clinical trials and receive grant funding from the Cystic Fibrosis Foundation. Sort of a high-level overview of the things I'm going to be talking about today. I'm going to begin by level setting, discussing some fundamentals of sleep, things we know about sleep, what we don't know about sleep, provide a high-level overview of what we know about sleep, particularly in cystic fibrosis, as well as other conditions that may influence sleep in cystic fibrosis, such as chronic pain and mental health disorders. And then the latter half of the talk, I'm going to talk about ways to get better sleep, and with a focus on the environmental factors and behavioral factors that can impair sleep, and kind of end with when should you seek a medical evaluation for sleep issues and what we can do for it. So sleep is one of the most highly preserved processes across biological organisms. So everybody sleeps, but sleep has historically also been fairly mysterious. I will just add that I can't see the chat. So if people have questions, feel free to stop me at any point, and we can, I don't want this to be overly formal, so please stop me and ask questions as we go along. But when I think about why we sleep, the body has a variety of biologic processes that are important for sleep. One thing I always think about with sleep is that it's a time for the brain to restore and repair itself. I tell people it's when the brain decides to take out its trash. So when we go to sleep and things become a little quieter, that allows the brain to offload some of the biological components, sort of to get rid of some of the waste products a little bit easier. We also sleep to conserve energy. We spend about a third of our lives sleeping, if not more, when you take into the fact that young children sleep even a greater percentage of their lives. So this is really important when we live in a somewhat resource-limited world. So if we were awake 24/7, we would need more calories. So it's important part of conserving energies. Another process that occurs during sleep is memory consolidation. It helps with processing of emotional memories. People who experience traumatic events, if they don't have good restorative sleep afterwards, they're more likely to have mental health disorders, including PTSD. But it's also important for memory and learning. When we think about learning, all those all-nighters I pulled in college probably didn't actually help me really imbue the knowledge into my brain. So it's also important in how we hardwire the electronic processes in the brain to provide memories. I mentioned infants. If you are mothers, you know that sleep and a young child and an infant is the vast majority of their day. And that's because the brain is really developing its most in these younger, in young childhood. So it's really important for growth and brain development. And even as we age, our growth hormone secretion, which is important to maintain insulin homeostasis and glucose homeostasis, that happens during the early part of our sleep. And then it also feeds creativity. And that's just sort of some of the softer parts of sleep, but it's important to help us feed creativity as well. What does good sleep look like? We know that sleep occurs in sleep stages. And the primary sleep stages are REM sleep, stage 1, which is very light sleep, stage 2, which is about 50% of our sleep cycle is in stage 2, and then slow wave sleep, which is our deepest sleep. So if you look, this is called a hypnogram, and this is a hypnogram of somebody who would be considered an excellent sleeper. They fall asleep quickly, so they go from awake right into stage 1 and stage 2 within the first 10 to 20 minutes after they get into bed. But within that first half hour of falling asleep, an individual who is a good sleeper will hit their slow wave sleep. And the slow wave sleep or deepest sleep occurs typically in the first half of the sleep cycle. And this is the period of time when the growth hormone and the other hormone secretions is at their maximum. Your first REM cycle, which is the rapid eye movement sleep, which has been associated with dreaming, occurs after about the first 90 minutes of sleep. And there are regular cycles of REM sleep over the course of the night, getting progressively longer towards the end of the night. In REM sleep, the brain is as active as it is during wakefulness. There's a ton of activity during REM sleep. And that's why we always say the muscles are paralyzed. And if you look at the EMG activity, there is clear atonia of the muscles during REM sleep. And that's what prevents us from acting out our dreams. There are some sleep disorders associated with loss of REM atonia, and these individuals can actually act out their dreams and be quite violent to their bed partners due to the activity in their brain. This is an example of somebody with very poor sleep. This might be somebody who has obstructive sleep apnea, who can't get into the deepest stages of sleep, or it could be even somebody with insomnia. So what are the things that make bad sleep bad sleep? Well, there are frequent arousals. You can see a lot of times that this individual has their sleep rise and awakening. And there are probably even more arousals. If you were looking at the 30 seconds of EEG, you'll see micro arousals spaced throughout the sleep. And this, when you see limited REM sleep and you see almost no slow wave sleep. So a lot of the restorative functions of sleep would be lost in this individual. And another thing that you see is that the patient's shifting between light sleep to stage 2 sleep, to REM, to awakening. So nothing is really maintained from one minute to the next often. And then finally, if you look at the total amount of sleep that this person would get, even though they were in bed for the same period of time as the last person I showed you, the percentage of total sleep time this individual would get would be much less. And the efficiency of their sleep would also be less. There are lots of reasons a person can get bad sleep. It can be either they can have a true sleep disorder that requires evaluation and treatment by a sleep physician. Chronic pain contributes to bad sleep. There are other medical conditions that can contribute to bad sleep, and depression and anxiety contribute to poor sleep. There are things that we can control in our environment or the habits we keep that influence our sleep. And medications we take also influence our sleep. Some of the medical disorders that lead to poor sleep, two of the most common ones that are associated with significant sleep disorders are heart disease, heart failure, heart arrhythmias like atrial fibrillation or stroke. These individuals have a high percentage of coexisting sleep disorder. We also see impaired sleep in lung diseases, including asthma, COPD, and CF. Renal failure has been associated particularly with both sleep apnea and leg movements and restless leg syndrome. I've mentioned chronic pain previously. As you know, heartburn can wake you up from a dead sleep really quickly. I would still like to highlight pregnancy. Pregnancy increases your risk of sleep disorders, so it increases your risk of sleep apnea. Pregnancy increases your risk of having iron deficiency, which is associated with the development of restless leg syndrome. It increases your risk of heartburn. A lot of pregnant women have difficulty finding a comfortable position to sleep. So pregnancy in and of itself is a significant impairment of sleep. And particularly when I think about this group, it's important to think about how pregnancy might impair your sleep. In addition to pregnancy impairing your sleep, sleep after childbirth, as we know, is quite impaired. So this shows mothers in the dotted line and fathers in the solid line. And not surprisingly, in that first year after a child is born, Sleep in mothers decreases on average by about 40 minutes per night, but over time, it never returns to its pre-pregnancy baseline, and mothers always sleep less than fathers. And mothers also report a much larger decrease in their perceived sleep satisfaction when compared to fathers. And it, again, never returns to its previous baseline, even at 5 years. And the more children, you know, as you can imagine, the more children you have, this says first childbirth, but in this study, you know, they had a second and third childbirth, and this same pattern was seen, although not additive, across all the increasing number of children being born. So what do we know about cystic fibrosis and sleep? A lot of the studies that we have looking at CF have been relatively small, but CF, not surprisingly, is associated with some degree of nocturnal cough. The studies that have been published to date are sort of in the pre-modulator era, so the pre-Trikafta era. It'll be interesting to see if some of the findings hold true, or if women or all individuals with CF are exhibiting improved sleep if on Trikafta. There is an association between circadian rhythm and CF, with individuals with CF having a greater tendency to be night owls. And there is some biologic basis for why this might be true. The consistent thing seen across a variety of trials is lower oxygen levels and more broken sleep or less sleep efficiency. And as lung function worsens, the risk for a true sleep disorder, sleep disordered breathing, actually increases. So this graphic shows measurements of a nocturnal cough. And again, this is in the pre-modulator era. In almost 60% of adults with CF reported that their cough interfered with sleep. In this study, they had a recording device that would record the number of measurable coughs per hour. So when they looked at the recording, most of the coughs occurred during daytime wakefulness, with an average cough per hour of about 40. But you can see when an individual goes to sleep, the coughs really tail off after the first hour or two of sleep. And there is some transition. So if there's a transition, the coughs go up quite a bit, and right when they wake up, the cough increases. But during sleep, most individuals only had about 1 cough per hour. And so this is, you know, while even 1 cough per hour could significantly impair your sleep, it's not all that dramatic overall. The other thing that was noticed was that during an exacerbation, the number of nocturnal coughs, they measured this in patients who were hospitalized. So the amount of nocturnal cough was about 4 per hour at the beginning of an exacerbation and would decrease to about 1 per hour toward the end of the exacerbation. I do see the question about the later circadian rhythm, and that's on the next slide here. So the group out of Utah, Ted Liu, who runs the Adult CF Center in Utah, has written about circadian rhythms and the role of CFTR in different areas, including the brain. So one of the hypotheses is that the CFTR has a role in at least 2 components that help set circadian rhythm. I don't realize this, but smell helps entrain what we call entrain your circadian rhythm. In addition, CFTR is important for retinal function. We don't think about that very often, but they've definitely shown that there's CFTR in the back of the eye. If you think about it, we're secreting fluid into the eye, so you need to have some CFTR within the eye itself. In addition, CFTR has been shown to be present in the anterior hypothalamus, and that is where circadian rhythm is set. So there is a role in multiple areas of the brain. And I think one of the interesting things about CF that we're going to need to learn in the future is what is all the roles of CFTR in the brain. That may, you know, and I know it's outside of the scope of what we're talking about today, but how does CFTR influence things like mental health? And I think that's going to be an important part of what we learn as time goes on. I want to talk about these two graphics, which are busy, but help us understand what's going on. So they had a really large number of both normal volunteers and people with CF across a range of lung functions. This first graphic is sort of just an overall overview of sleep. So in the bottom, in the blue boxes, is the sleep latency. So compared to normal volunteers, it took individuals with CF a little bit longer to fall asleep on average. So about 30 minutes versus about 20 minutes to fall asleep. In addition, the total amount of sleep was a little bit longer in CF patients. So instead of about 8 hours compared to normal individuals, an individual with CF would get closer to about 8.5 hours on a daily basis. And this, on the second half of this graphic, shows the clock hour. So compared to normal volunteers, CF patients on average were going to bed after midnight and waking up closer to 9 a.m. So there's this delay in both sleep onset and wake time. And this gray is the mid portion of sleep. So CF patients go to bed later, sleep in later, and have a delay in their midpoint of their wake time compared to normal individuals. And it's not influenced by the percent predicted FEV1. This was pretty steady across all levels of FEV1. And I know from my own experience in the hospital, and I'm sure you guys, if you've been hospitalized, have experienced this as well. CF patients don't like being woken up for the early morning rounds. I don't know how many times I round and I see that sign on the door that says, please do not wake me until after 9 a.m. And this has been true across my entire period of training in medicine and cystic fibrosis. The other thing we know about CF is that oxygen saturation is lower. And it's interesting that this was shown to be true even in infants, because we don't even, we think of infants with CF as being relatively healthy. Now, again, we're going back 20 years, so this is going to be probably a slightly different group of infants. But if you look at this, particularly the symptomatic infants, during sleep, their average oxygen saturation was about 2 percentage points lower. And the time they spent with an oxygen saturation that was less than 93% in these small number of infants was about 10%. And then this all holds true throughout childhood. And then when you get to adulthood, there's even a greater impairment in oxygenation. And it's interesting because once we get to adulthood, we're seeing that not only is it oxygenation that's impaired, but patients with CF had higher heart rates, higher breathing rates during sleep, a lower awake oxygen saturation, a lower mean oxygen saturation. And this TST is time spent less than 90%. About the individuals in this study, about 30% of the time had an oxygen saturation of less than 90%. Again, we're going back quite some years for these studies to 1999. So the individuals in these trials are a lot sicker than the people that I see today. So it'd be interesting to see newer studies that investigate oxygen levels in a healthier group of patients. With lower lung function, if you compare groups of patients who have this desaturation during sleep to groups of patients who had no desaturation during sleep, you can see that the patients whose oxygen levels go down had much lower lung function, about half, almost half the lung function as those who had more normal oxygen levels. And this holds true with looking at what their awake oxygen saturation is as well. So, and this holds true in CF. This is what I also tell my patients with COPD. If your awake oxygen saturation is averaging about somewhere between 90 and 93%, when you go to sleep, you're probably going to have oxygen desaturation. And when you compare this, however, overall, patients with CF tended not to have obstructive sleep apnea. And most studies show no increased risk of sleep apnea unless there's severe impairment in lung function to the point where maybe somebody might need nocturnal ventilation. There are links between the immune system and sleep, and I think it's important to think about that as well when we know that CF is an inflammatory disorder. When you get sick, a variety of cytokines, what we call cytokines, go up. One such cytokine is TNF alpha, that stands for tumor necrosis factor alpha. That is the cytokine that contributes to fevers. And this cytokine impairs sleep. It causes more sleepiness, kind of gives you that groggy feeling like, you know what, I need to go to bed right now. And we also know that in experimental conditions, when you induce both acute sleep deprivation, and I would never volunteer for these studies, but an acute sleep deprivation study, they keep you awake for sometimes as long as 72 hours without letting you fall asleep. And then there's longer studies with chronic sleep deprivation where they prevent individuals from getting more than 4 hours of sleep per night. And when they do that, they see that these individuals start to exhibit impairments in their immune system with elevations in their white cell counts, elevations in their cytokines. So not getting sleep is a significant inflammatory stimulus. This is another study where they kept people in a restricted sleep environment. So for multiple days in a row, they would keep them with 4 hours of sleep a night, let them do 2 or 3 days of catch up, restrict them again to 4 hours of sleep a night. And so this would be somebody who is in a research center for 24 consecutive days. And when they compare the people who had restricted sleep to control sleep, when they restricted sleep, generalized body pain goes up, headache goes up, back pain increases, and stomach pain increases. So your body's sensitivity to pain changes dramatically if you're restricting your sleep. And when they exposed the people who they were restricting the sleep to experimental conditions where they exposed them to cold, like dipping their hands into ice and seeing how long they could keep their hands there, or keep their hands on something that's hot, when you're sleep restricted, your sensitivity to heat and cold changed significantly as well. When we think about mental health, patients with insomnia have a 10 times risk of developing depression. Impaired sleep is a risk factor for suicide. And when we look at the sleep studies and what their sleep looks like in individuals who have depression, they show a loss of that slow wave sleep and an increase in REM sleep with increased intensity, so more vigorous eye movements in individuals who have depression. On the flip side, anxiety is considered to be what's called a hypervigilant sedate. So people who have chronic anxiety often they're just sort of revved up. They have these racing thoughts. They have a hard time turning off their brain. And when we look at their sleep studies, they have more of that lighter stage 1 sleep and sometimes more stage 2 and less of that slow wave sleep and more arousals from sleep. Some of the medications that can impair sleep are listed here, but if you go into drugs.com, you probably are going to find any number of medications. Almost every medicine can impair sleep. Some of the ones to highlight are steroids. Acutely, steroids often cause that jittery feeling that impairs your sleep, but it can also cause more chronic impairment with insomnia and decreased REM. Antihistamines, when we think particularly about Benadryl, Benadryl is probably the #1 sleep aid used by most people. That can, of course, cause that sense of drowsiness. And histamine itself is one of the neurotransmitters in the brain that is most stimulating, that helps us maintain wakefulness. So if you take away histamine by using an antihistamine, you're going to, by very nature, feel sleepy. The antidepressants, if depression causes an increased intensity of REM sleep, these antidepressants are going to decrease your REM sleep, but can lead to daytime fatigue. So these are some of the highlights. I think in CF, some of the other things I think about are albuterol, which can be quite stimulating. It is a sympathetic nervous system stimulant. So that can cause impairment, particularly in falling asleep. But most of the CF medications in general are like Dornase or Trikafta have not been shown to have any issues related to sleep. Although I guess Trikafta is probably too early to have had any more significant studies other than a few case reports. There's a host of non-medical reasons people would get bad sleep, and a lot of them are behavioral factors. Keep maintaining an irregular sleep schedule is probably the number one factor for most people. Electronics, we all are on our phones or tablets, often late into the night. Increased streaming and having availability to watch TV on tablets in our bedrooms, et cetera, are probably impacting our sleep quite a bit. And not having the right environment can impact our sleep. And we're going to talk a little bit more about these as I go through. So every year, the National Sleep Foundation puts out a Sleep in America poll. So I like to go back through some of these polls from time to time. And this one, some of the questions, because they ask different questions, so they have different focuses in different years. But the people who felt like they were most well rested were the most disciplined. So not deviating their sleep time or their wake up time by more than an hour. Those were the people that were the most well rested, that felt the best. But the people who had more erratic sleep and wake times were the ones that really tended to be poorer sleepers. Caffeine is good in moderation. We've been using caffeine for thousands of years. I was listening to a podcast called Gastropod about caffeine and coffee, like sort of the history of coffee, which I thought was really interesting. But they were talking about how caffeine and the increased intake of coffee was associated timing-wise with the Industrial Revolution. And, one of the hypotheses is that improved worker efficiency is kind of giving them that coffee break. Who knows if that's real or not, but it's interesting to think about the history of coffee. Everybody's sensitivity to caffeine is very different. And people tend to get more sensitive to caffeine as they age. Caffeine does prevent your sleep onset. It increases arousals. It competes with acetylcholine in the brain. It binds to the acetylcholine receptor in the brain. And acetylcholine is one of those things in the brain that make you feel sleepy. So when people are telling me they're having difficulty sleeping, I advise no caffeine after about noon. That's the advice I give. It's not the advice I take, because I often have a mid-afternoon cup of coffee, and I look forward to my mid-afternoon cup of coffee when we finish here. I like to show this table to show the amounts of caffeine in different substances. I think a lot of people think, oh, Mountain Dew or Red Bull has a lot of caffeine, but really your caffeine is going to be from coffee, and a drip coffee is going to have more caffeine in, typical than an espresso. Of course, an espresso is like 1 shot, 1 ounce. So depending on how much espresso you get, you can really pack in the caffeine there. Alcohol, historically, that little nightcap before bed, and people would say, well, alcohol helps me sleep. But the reality is alcohol over the course of the night impairs your sleep. So it may help you fall asleep faster, but it leads to suppression of REM, particularly in the first part of the night, and maybe some more slow wave sleep in the first part of the night. But the most problematic problem with alcohol is what's called REM rebound. With REM rebound, you get these really intense dreams later in the night, and you get longer periods of REM later in the night. And subsequently, you also get more broken sleep. So after a night of drinking, people often report just really feeling fatigued and impaired the next day. And it's not just the hangover, there's a true impairment in sleep. This is another Sleep in America poll from this is going back 10 years. And it's notable that 60% of all respondents had a television on in the bedroom within 1 hour of sleep. And at least a few nights a week, particularly the younger generation, were on a computer or social networking site within the hour before bedtime. The older generations, myself and the Gen Xers and the baby boomers were less likely to be on the internet or using a computer. But I would bet over time, we're actually seeing these numbers increase. So why is technology bad before bed? Well, these expose you to blue light. And blue light is very stimulating to the back of the eye, to the pineal gland, to reset your circadian clock. So when you're exposing yourself to blue light, you're actually telling your brain that it needs to stay awake longer. So it's pushing back, the pineal gland secretes melatonin, it's pushing back that nighttime melatonin release to allow you to fall asleep easier. So use your blue blockers or the blue light blocking glasses. I've actually started to wear blue light blocking glasses a lot of times during the afternoon in my computer. I find actually that my eyes, even if they're not reading glasses, my eyes feel less stressed when I'm looking at the screen with the blue blocking glasses. Other environmental factors, when people are asked to rate the environmental factors that are most important, it's the way the sleep environment is set up. So what pillows are you using? What sheets are you using? What's the temperature? How dark is it? Less likely is what the bed partner, whether it's a partner snoring, a pet in your bed, or your children in your bed, or partners moving. But the biggest factors that are influencing sleep is just how comfortable is it. Interestingly, there was a study published looking at people sleeping with their dogs and how their sleep was impaired or not impaired. And I think it probably depends on the dog, I'll be honest. So if you look at the time of sleep of the human, 85% equals almost exactly the percent rest time of the dog. So if your dog is a good sleeper, you're going to be a good sleeper. I guess probably same thing could be said for your children. But if your dog is a bad sleeper, very active at night, you're going to have probably more wake time at night. So what are the things that we can do to be better sleepers? And one's figuring out what's the right environment for you. So you need to figure out what your best schedule for you is and stick to it. Figure out what your circadian rhythm is. I think a lot of people who are phase delayed, which includes, that's the night owl people, that's what a phase delay is. Those are the night owls. And I was among them for most of my life. And if you give me free reign, I still would be, but I have been very vigilant about my schedule. And the thing that made me get vigilant about my schedule was having children, knowing that, when you have children, it's really hard. They're not going to vary their wake times very much. So once I had kids, I knew that if I ever wanted to feel even moderately rested, I need to keep myself to a schedule. But sometimes, particularly for people who are phase delayed, the environment, the rest of the world doesn't want to work around you. So you need to be at work by a certain time. In this day and age where a lot of people can work from home, I think there's probably more flexibility on work schedules. We're starting to see that more. So maybe the people who are phase delayed will have a little bit a better time in the future. So I mentioned the right environment. So most people sleep best, and they have studies that show this, that most people sleep best with a temperature between 65 and 70 degrees. So keeping that bedroom cool at night. Use the room darkening curtains to try to keep your room quiet. Use a sound machine if you have noise pollution, a white noise type machine, or play light music. And invest in a good bed. I think that's a long-term investment that I think it's an important investment to make. People need about 7 to 9 hours per night. The graphic I showed you with the individuals with CF, they were sleeping a little bit more, like about the 8.5 hours on average per night. And they've looked at people who average less sleep. So if you sleep less than 5 hours or more than about 9 to 10 hours, that's associated with increased risk of developing heart disease, increased risk of developing cancer, and even an increased risk of death. So perpetually short and perpetually long sleepers have more medical risk. In addition, they looked at nurses. There was this really big study called the Nurses' Health Study. And when they looked at people who were on a night shift, who were perpetually awake at night, when biologically, you even among people who were even pretty significantly phase delayed. So even people who are phase delayed have some sleep at night. But if you look at nurses who are always night shift workers, they had an increased risk of cancer. So if you want to kind of think about your sleep and look at your sleep, a lot of people are using sleep trackers. As a provider, I find sleep trackers helpful as a starting point for a conversation, but it can't be the end point for what's going on in somebody's sleep, with somebody's sleep. So I think of a pro is, but the first thing is what information can it provide you? Everybody has a smartwatch now, or you can use apps, you can use a variety of different things. But first is just, what are my trends? You may think that you keep a reasonably consistent schedule, but when you track it, the next thing you know, you realize like, oh, some nights I go to bed at 10 and some nights I go to bed at 1, and there's no consistency at all to it. You can use it as a tool, as I mentioned, to engage a provider. They can be as inexpensive as a piece of paper. If you go on the AASM, the American Academy for Sleep Medicine, there are graphs that you can download that show how to monitor your sleep. Or it can be an app you download on your phone that helps monitor things. But so it can give you kind of these real-time feedbacks to sort of help you understand what your own patterns of sleep are. The cons are, well, they're great in theory, but like, what does it really mean when we go and measure sleep in the sleep lab? And we don't have a lot of data for most of these, and most of these are not evaluated by the FDA. And some people get really keyed in. There's actually a disorder called orthosomnia, where you start to develop anxiety about your sleep tracker, which therefore perpetuates your insomnia. So it just becomes its self-fulfilling prophecy. So an example of a sleep tracker, I see that question there, is of course a watch, like your Apple Watch, but there are things that you can download. This one is called Sleep Score, and it uses things like measures. It can use movements. It can use sound, like it's basically listening in on you all night. It does give these apps do give Big Brother a little bit more insight into your life than maybe what a lot of people might like. It can use, some of them use sonar, and there are even beds that have sleep trackers. I'm sure some of the newer beds, like from Sleep Number, have abilities to measure your sleep built into the mattress, it can measure things like your breathing rates, your body temperature, your heart rate while you're sleeping, kind of built into the mattress. When should you ask for help? So some of the common sleep disorders, sleep apnea. Sleep apnea is among the medical conditions that we see, probably the most common. So loud snoring would be the thing to think about and listen for. So more so male partners come in saying that their female partners say that they're snoring than vice versa. But snoring is more common in cystic fibrosis. So there is, of course, increased risk of sinusitis in CF. So with the sinusitis, you get some degree of nasal obstruction, but nasal obstruction is not obstructive sleep apnea. What happens in obstructive sleep apnea is there's an obstruction in the back of the throat where the tongue kind of meets the uvula and right above the epiglottis. And these in individuals who have obstructive sleep apnea have repetitive closures of the throat. So snoring alone isn't it. However, if you have nasal obstruction from a lot of sinus problems, obviously you have to sleep with your mouth open. And when you open your mouth, that increases the risk of having these obstructive apnea events. They're more common when you're on your back than when you're on your side. They're more common in women after they go through menopause. So those are some things to think about with obstructive sleep apnea. Some clues, and these are very generic clues outside of snoring, are increased daytime sleepiness to where you just really can't function. Waking up with a dry mouth, waking up with a headache in the morning. Those can all be kind of clues in that something might be going on. Central sleep apnea is more rare. Central sleep apnea is when your brain tells you to stop breathing. That can be related to medications. Probably one of the more common reasons we see it related to medications is related to use of narcotic pain medications, because they have they stimulate or fail to stimulate, they inhibit the brainstem respiratory rate. Other times we see central sleep apnea is in diseases like heart failure. Probably the single most common medical disorder is insomnia. Insomnia has no easy fix. I will say that, people who have insomnia often have insomnia for years. And it tends to get, there are times it can be stimulated by something and then you kind of forget how to sleep well. Restless leg syndrome is associated with iron deficiency, so therefore it's more common in women. And I do see a fair amount of iron deficiency in individuals with cystic fibrosis. So if you're noticing sort of this restlessness, it's important to talk to your clinical team about having your iron levels checked. Restless leg syndrome is not somebody telling you you're moving your legs in bed at night. It's this almost irresistible urge to move your legs at night. And some people have to get up and walk around. Some people are just rubbing their legs back and forth in bed, but it's the sense that your legs must move. And then there are a few disorders of hypersomnia. Narcolepsy, which I think is the one people hear about, is actually pretty rare. There's not a lot of cases of narcolepsy. Most of the people who say, oh, I'm just really sleepy and maybe I have narcolepsy, probably have some other sleep disorder or medical condition. There is a medical condition called idiopathic hypersomnia, which sounds exactly like what it is. You're sleepy and we don't really understand why you would be excessively sleepy. But a lot of the people who have idiopathic hypersomnia are the people who biologically need more than 9 to 10 hours of sleep, and often more than 10 hours of sleep. So when we think about the need for sleep, it kind of is on a bell-shaped curve, and only about 2% of people at either end either need less than the 5 to 6 hours or more than 10 hours of sleep per night to feel rested. But in a world where people have expectations, getting up and going to work, those kinds of things, people who really fall in that 10 hours of sleep or more are often disadvantaged, that they just can't get all the things done that they need to get done in a 24-hour day. What are some of the things to do if you can't sleep? I often tell people that your bedroom, particularly if you're prone to insomnia, your bedroom should be for sleep and sex, and that's it. So if you can't sleep, get up out of bed after about 20 to 30 minutes. Don't stay in the environment that's going to perpetuate your sleep. When you get out of bed, do low light activities, listen to music, read a book, an actual book. Or if you're reading off of an e-reader, make sure it's low light or with a blue blocker in place. Sleep aids such as melatonin or Benadryl, they may help slightly, but in the long term, they're not going to increase total sleep time all that much. And even prescription strength sleep aids such as Ambien lose their efficacy in most individuals over time. So severe persistent insomnia really requires a lot of hard work on participants. You have to retrain your brain to sleep. The most effective thing for insomnia is actually cognitive behavioral therapy for insomnia. The problem with cognitive behavioral therapy for insomnia is there's not a lot of therapists who've been trained to provide cognitive behavioral therapy specifically for insomnia. That's its own sort of subset of a sleep disorder specialist. And we do work with psychologists often in sleep clinic to help people with cognitive behavioral therapy. But there are online programs. There's one I listed here, this mobile.va.go. And this is some screenshots of that app. When you're dealing with insomnia, they do a variety of different techniques in cognitive behavioral therapy. I think one of the hardest for people is sleep restriction. A cognitive behavioral therapist will say, well, your sleep window is going to be this 6-hour period of time. And until you consolidate your sleep well in that 6-hour window, you don't get much more than that. You don't get, your sleep window doesn't increase. So that means no naps, no sleeping in, no changing what time you go to bed. So that's why I say it's really hard work, because like anything, like the behavior has to change to sort of retrain your brain to learn how to sleep. And so cognitive behavioral therapy is an important piece of treating insomnia. So I'm ending here. This is sort of my final thoughts. I think sleep is interesting. It's linked to a lot of our biological processes, and we don't fully understanding all the complexities of sleep. I think better sleep health begins with creating the right environment and knowing yourself and knowing what's going to be best for you. And then I would encourage you to seek help for your sleep disorders if you're concerned that you might have one. So I'm going to